Ahí, más un poquito arriba. Ahí ve un botón.
¿Un botón?
De un lado para otro.
Ah, sí. Ya lo hice para la izquierda.
Perfecto. Good. Está bien, muy bien. Okay. Bye bye.
Oigan.
No, tu microphone muted cuando no estés hablando.
Perfect. Is it okay we go live now?
Yes, we're good. I see Adria Costa, Diana, how do I say your name? Pursuit?
Pesad.
Persad. Francisco, hola Francisco, Inés Lariguet. Y Johanna. Good, welcome everyone.
Hi, Dr. Bischoff.
Dr. Bishop, can you see me?
No, you're black now. I can hear you.
I'm having trouble with my video. I don't know why. It just happened now.
So what? I saw you before. Maybe log out and log back in.
Okay.
Recording in progress.
Here we go.
Good morning, everyone, and welcome to our monthly International Colorectal Web Meeting. Today, we have pediatric surgeons joining from Argentina, Trinidad and Tobago, Italy, Mexico, Iraq, Uruguay, Brazil, Russia, Sudan, and Uganda. If I haven't mentioned your country, please type in the chat and I will acknowledge at the end. We have today several presentations, so I'm just going to ask whoever is not presenting to please mute your microphone, otherwise we hear a lot of echo. The first presentation comes from Buenos Aires, Argentina, and will be presented by Dr. Inés Latigue. Welcome.
Good morning. There we go. Can you see the film? Yes. Good morning. My name is Inés Lariguet. I'm a fourth-year resident at Posadas National Hospital in Argentina. I'll be presenting a case of a neonatal rectal prolapse. This is a female patient born at 26 weeks gestational age with a very low weight, depressed Apgar requiring resuscitation and intubation. It was a product of a controlled monochorionic diamniotic twin pregnancy. She had fetal normal ultrasound. She passed meconium on the first day of life. As a neonatal, very low weight and preterm, she had several complications: hyaline membrane disease leading to respiratory distress, bronchopulmonary dysplasia, grade 2 intraventricular hemorrhage, patent ductus arteriosus that responded to indomethacin, and she had septic shock, cholestasis, and right inguinal hernia. We have on the left side of the film rectal prolapse that the patient had at 1 month age. At this time, the patient was with a septic shock and the prolapse was non-reductible. So we started with a conservative treatment, but the patient evolved over the months, leading to, as you can see in the right side of the film, increasing size of the prolapse, adding erosions and bleeding, and difficulty to pass meconium. The patient was slightly obstructed. Additional studies were done to evaluate the patient. An abdominal ultrasound showed hepatosplenomegaly and an amount of free fluid in the left lower quadrant, loops with little peristalsis, echocardiogram with patent foramen ovale at 3 millimeters, and both lumbosacral ultrasound and MRI were normal. We studied that for threaded cord. Well, there are a lot of challenges in the patient. First of all, the prematurity and the low birth weight increase vulnerability to complications. Sepsis can exacerbate inflammation. Bronchopulmonary dysplasia was the most important thing and complicated things because it delayed surgical intervention. The patient had requirement of oxygen support by high flow nasal cannula. The persistent prolapse increases in size over the month and became adding erosions, mild bleeding, and pain during bowel movement, making very difficult to reduce and altering the anatomy and causing discomfort in the patient. There was also a nutritional challenge. The patient was weighing 1,820 grams and was very difficult to increase in weight. So we discussed different treatment strategies. First of all, non-surgical management with manual reduction. It was very difficult. Topical treatments, we add dressings to prevent inflammation of the rectum. And at that time, the patient was leading to have indications for surgery, persistent relapse, and complications such as erosion, bleeding, or obstruction. So we started to think about rectopexy, sclerotherapy, resection, circlage, or colostomy as a surgical procedure to be done. So the first question we have is, how effective do you think How effective do you think the non-surgical treatment options, manual reduction, topical treatments, and infection control were in managing rectal prolapse? Sorry. Well, there are several answers. Second question we have is preferred surgical approach. Given the case details, which surgical treatment strategy would you consider the most appropriate for rectal prolapse? Rectopexy, sclerotherapy, third clutch, resection, ostomy. Rectopexy was the chosen one. So let's show you what we done. The patient was in a very bad clinical condition, so we decided to perform a reduction of the prolapse, as you can see in the left image, and to perform an ostomy to allow nutritional enteral feeding. So as you can see in the right image, the prolapse was completely reducted, and the ostomy was performed on the left lower quadrant. The patient evolved with local recurrence, but in a milder way than it was before, that we were allowed to reduct with a compressive local dressing. Ostomy was vital and functional. Nevertheless, the patient evolved with critical condition. She had pulmonary hypertension, required high flow ventilation and nitric oxide. The patient's condition worsened, leading to death because of the pulmonary hypertension. So the questions we have is, what alternative non-surgical treatment strategies would you consider? What alternative surgical treatment would you choose? When would you perform surgery? What experience do you have regarding the treatment of rectal prolapse in neonatal periods?
Thank you very much for this very interesting cases. If people have questions or comments, please type in the chat. I think everybody will agree this is a difficult situation. We have had one similar case, and the baby was with tracheostomy and continuous ventilation, and always almost like trying to cough. So a lot of intra-abdominal pressure and a huge prolapse that was very hard to reduce. For that patient, Dr. Peña and I actually operated. We did a laparotomy, a big one, and a rectopexy. We had very little hope that it was going to solve the problem, but we feel that those patients should be approached stepwise. So you try one thing, if it doesn't work, you go for the next more aggressive one. And just explaining to family and the medical team that we don't have the perfect treatment, especially when the cause of the intra-abdominal pressure will not stop, like in a patient with bronchodysplasia. So the only thing is cerclage. I think we have to be very careful, because what we are doing is making a strictured anus. So we just have to be careful. In a case like the one you showed, that the prolapse is so big and there is a cause, I agree, and I think most people would agree that the sclerosing therapy is not the best option. So I'm sad about the end outcome of this patient. And the only thing, once we decided to do a stoma, I think I would try to make a stoma, in this case, the distal one under tension, try to fix that rectum. So not leaving, you did, and it still prolapsed a little bit.
We wanted to be tight, so the prolapse wouldn't appear again, but I think the patient had a very redundant mucosa. So that was what made the recurrence.
Dr. Peña, Dr. De La Torre, do you have comments?
they mentioned that the ultrasound of the spine was normal, but I would like very much to see an X-ray film of the spine, because the ultrasound detects certain problems such as tetrachord, but I'm not sure about the accuracy of the ultrasound to see the integrity of the sacrum. I would love to see if the sacrum is complete, entirely complete. And it's a difficult case. And it's not a bad idea what you did, a colostomy, a very distal colostomy that will actually act like a rectopexy. And but I try to look for what's the origin of this, what's the cause of this, and because so far we are treating something and we don't know the origin of that. So I don't have more to say about this very difficult case.
Dr. De La Torre?
No, at this age, I think the colostomy and the rectopexy will be the options. I don't have experience in these patients, in neonates. I never have seen these patients.
Thank you. Any other comments or questions? If not, we're going to move to the next case that will be presented by Dr. Francisco Imaz from Buenos Aires, Argentina again.
I just want to say, Andrea, if they did a cystic fibrosis test.
She had the screening negative, the FAE.
What screening?
I don't know how to say it in English, but el FAE,
in Spanish.
El FAE es la pesquisa neonatal que hacen en todos los recién nacidos, al nacimiento, digamos.
I would suggest to do the genetic test.
Yeah,
no.
the patient passed away, so I don't think they will do it now,
Oh,
but
sorry.
yeah, in the future.
And let me say,
Family.
Dr. Larry, I'm sorry, Luis.
Sorry.
Dr. Larry, we will appreciate if you
Family.
give us a follow-up in this case in the coming months. Don't forget that it's very interesting for us.
The patient passed away, Dr. Peña.
What?
The patient passed away from the bronchopulmonary dysplasia.
Okay, so we'll wait for the next one.
Okay, but the family is alive, so they need to study the family, because if they want to have another kid.
Okay, Dr. Francisco, please present your case. You're muted. Francisco, can you hear us? I think Dr. Francisco is having trouble to put your microphone in your presentation.
Can you hear us?
Okay, what we can do, let's go to Dr. Adria Costa case, and then we go back to Dr. Francisco.
Okay.
So
Hey,
Adria Costa is presenting from Hospital Infantil de Mexico. Hi, Emilio, in Mexico City.
Morning. Please let me know if you are showing my presentation. Do you hear me?
We hear you, but we can't see it yet.
Okay. Now?
It's coming.
Okay.
Can you go on the presentation mode without the side screens? Perfect.
Okay. Well, first of all, good morning, everyone. Thank you for letting me presenting a challenging patient. The patient we are presenting, it's a female baby of 36 weeks of gestation and a 2.3 kilograms. She was born in another center in our country with a prenatal ultrasound revealed an abdominal wall defect, but it wasn't specified. She was transferred on day 12 of life with the features in the physical expression that you can see in the picture as a colocal extrophy with omphalocele that was closed. As a preparative workup, we ordered an abdominal, renal, and spinal ultrasound observing right kidney ectopia And on the spinal ultrasound, we couldn't rule out dystrophism. As a preparative workup, we also ordered echocardiogram showing a 2.1 millimeter lateral septal defect with no systemic repercussion. And given the previous findings, what should your GI approach be? Omphalocele closure plus ileostomy, omphalocele closure plus colostomy, omphalocele closure plus second plate rescue and terminal colostomy, or the answer that it's helped me? Okay. Actually, it's quite a tricky question as we have two correct answers in this question. Obviously, and first of all, if your center are not experienced with complex colorectal disorders as local extrophy, it is better to transfer the patient to another center. And if you have the opportunity, it is better to first close the omphalocele, then rescue the second plate, and finally do a colostomy as a terminal colostomy. So this is the intraoperative findings. We start a midline incision in the superior aspect of the omphalocele. We enter to the cavity and we dissect all the omphalocele. After that, we reference both the hemibladders with 5-0 silk stitches in the superior aspect of it, as you can see in the right picture. We also do a traction stitch with silk in the second plate, in the posterior aspect of it, as you can see here, that it's widely open within the two hemibladders. And we start dissecting all the second plate from the hemibladders. Here we are freeing the second plate from the last attachments. And once we have the second plate completely free from the hemibladders, we need to perform 2 layers closure of the second plate, in this case with a 5-0 braided absorbable sutures. In this case, we were some lucky because we had 6 centimeters long of terminal colon, as you can see here in the picture. And on that colon, we perform a colostomy. We pull through the abdominal wall and mature as a colostomy. Once that we have done that, the pediatric urologists also enter with us. We start first of all, catheterizing the ureters with the 5 French catheters. And then we start the closure of the hemibladders, firstly in the posterior aspects with 5-0 absorbable sutures. We have to resect also, dissect also the lateral aspects of both hemibladders, as we can see here. And finally, do it the same in the anterior and inferior aspects of both hemibladders. So based on what we found, what should you do with both hemibladders? The closure of it and leave them as a bladder extrophy, closure of the hemibladders, and complete reconstruction of the abdominal wall with pubic bone approximation. It depends. And finally, the answer that it's helped me. Okay, that's good. Also, this is also a tricky question as it has 2 possible answers. Again, if your center doesn't have a good pediatric urologist, it is better to transfer this patient to another center with more experience on that kind of problems. And also, it depends on the anatomy of the baby, it depends on the team that it's performing the surgeries, because both approaches are good. We went for the B answer, sorry. So we closed the hemibladder in the anterior aspect with also the same suture. And after that, we mobilized the pubic bone and we use U-stitch on it to approximate the pubic bone. It had 8 centimeters of gap, and after the closure of the pubic bone, it was less than 1 centimeter. So this is the final picture before we close in layers, and this is the final aspect of our patient with both catheters exteriorized through the abdominal wall in a contralateral fashion. As a post-operative course, the baby was nilperose and total parenteral nutrition for 7 days with broad-spectrum antibiotics and ureteral and bladder catheters in place. Colostomy was passing the stools on day 3, and post-operative day 18, the patient reached out full enteral feedings, and colostomy was passing stools. Actually, we are discharging her on this Saturday. As a discussion of treatment strategies that we perform, we don't encourage terminal ileostomy in these patients. If we have a good length of colon, it's better to perform a colostomy. And if we don't have a good colon, it's better to tubularize the cecal plate and pull through it from the abdominal wall as a terminal cecostomy. But it is better to rescue the cecal plate in all these patients. And as the repair of the bladders, we can go for a complete primary repair, as in this case, or a staged bladder repair with 3 procedures. Both techniques have cons and have pros and cons, and depending on the experience of your center and depending on the anatomy of the baby, it is better to perform one or the other. Just some take-home messages. Always expect the unexpected on these patients. Always approach the babies as a multidisciplinary team with experienced colorectal surgeons and pediatric urologists, and always do a tailor patient's care and individualize depending on the case. Thank you for listening to me.
Wow, congratulations. What a beautiful case and very well handled. One of the most common mistakes in cloacal exstrophy is opening a ileostomy and leaving distal bowel unused. So patients with cloacal exstrophy, they have different colonic length, but we have to use the entire colon and place it within the fecal stream, so creating a true end colostomy to allow this colon to grow. So in the future, we can decide if this patient is a candidate for a stoma pull-through or not. So very well handled. Regarding the bladder closure, I think it depends if it is possible or not. Sometimes when you attempt the closing, the intra-abdominal pressure is so intense that the patient cannot handle. So in some cases, even the omphalocele, if it's a very large omphalocele, sometimes we are not able to fully close the omphalocele or to fully close the bladder. So I think in those cases it depends, but it's, as you mentioned, very important to have a multidisciplinary team and very important to do the adequate treatment, which was done in this case. So congratulations. My only question, did you inspect Müllerian structures? Did this patient had hemiuterus and vaginas?
Yeah, she had both hemivaginas, but the left hemivaginas was stricter, so it was not going to function, so we resected.
Okay, perfect. Usually those patients have 2 hemivaginas and hemiuterus that are very, very far apart. Congratulations. Dr. Peña, any comment? Dr. De La Torre, any comment?
Congratulations to our colleagues and friends from the Hospital Infantil de Mexico. That's a great case, very elegant, very neat presentation, very clean, not bloody, so doesn't look like an explosion in a meat factory. It looks clean, like a nice pediatric surgery. Congratulations to your team. But let me say, based on the total reconstruction of this case, you cannot claim that the ideal treatment is the primary complete repair, because as Dr. Bishop suggested, everything in cloacal exstrophy is a spectrum, like all congenital malformations. There are cleft lips and cleft lips and cleft lips, and each one requires a different strategy, a surgical strategy. So you were lucky with this case. In addition to the good technique, you were lucky, but not all the cases you can do this primary closure, because there are cases, for instance, all the how separated was the pubic bones, were the pubic bones. And in all the cloacal exophytes that I have seen, I have never seen a permanent approximation of the pubic bone. It's very difficult to really bring them together. And one more thing, it is important to follow up the condition of the kidneys, because it has been reported in once you close the bladder, which is not easy, when you close the bladder, sometimes there is a kink in the ureters, and the patient develop later megaureters and hydronephrosis. So it's great what you did, but most of the times, in fact, I have never been able to make a primary closure of a cloacal exophy, but you did it, and the successes are not discussed. You were successful, congratulations, but be ready for the next one. And don't expect that you will be able to close it as you did in this one. Thank you for your presentation.
Thank you so much, doctor.
So there is one question about leaving the cecum in the pelvis to augment the bladder. So that's exactly what we are talking. All the intestine of the patient should be used into the fecal stream. That's the only chance for this patient in the future to be a candidate for a pull-through. What we do when these patients reach 3 years of age, we do bowel management through the stoma. If they succeed, if they have an empty bag for 24 hours, then we can offer as a quality of life decision to bring the stoma as the neo-anus, and they will do enemas every day to stay clean. If they fail, and we have decided this patient will have a permanent stoma, then urology can choose what type of tissue they want to use to augment the bladder, and sometimes they may use colon. That's not their preferred option. Nowadays, they prefer to use ileum.
And
So,
one question, did you leave catheters in the ureters at the end of the operation? Because,
Yes,
and I insist, you have to follow up with kidney ultrasounds to be sure that they don't become dilated.
sure. We left them, doctor, and we are going to wait for the next ultrasound.
wonderful. Congratulations. Francisco, are you ready to try again to present your case?
Hi everyone. Yes, I'm ready now.
Perfect. Let's
I'm
go. And we
sorry, I
have
had
Dr.
some Wi-Fi
Alanis
problems.
online. Perfect.
Okay, can you see me?
Yes.
Yes.
Okay, thank you. So, hi everyone, my name is Francisco Imas. I'm from Buenos Aires, Argentina, and today I'll share with you this challenging case of a cloacal malformation with an acquired vaginal atresia. So this is the case of a patient, as I told previously, with a cloacal malformation who was treated previously on another center and consulted to us for the first time at the age of 17. So regarding her medical and surgical history, she was born with this malformation with a common channel between 1 and 3 centimeters, with a cross-fused ectopic kidney, but no other associated anomalies, no hydrocolpos, and no cardiac anomalies. And regarding the surgical history, she had done a colostomy at birth, and when she was 1 year, she had done the surgical cloacal repair with an anorectoplasty and a total urogenital mobilization. After that, she had a severe constipation with recurrent fecal impactation, requiring a sigmoidectomy because of a dolichomegasigma, and she also had done a Mitrofanov at the age of 13. It wasn't clear the indication, but from the family's history, it was a mictional disorder. In this case, it was only a Mitrofanov without a bladder augmentation. Regarding the renal history, she has a functioning single kidney and she had multiple urinary tract infections. Her current glomerular filtration rate is 45 millimeters per minute, and her actual urea is 61, and her actual creatinine is 1.37. Now, regarding the current illness, she consulted to us because of abdominal pain associated with primary amenorrhea. At the physical examination, the abdomen was soft and depressible, but tender predominantly in the left iliac fossa where a mass was palpable. The ultrasound and the MRI showed an uterus with hematometra measuring 15 by 7 by 8 centimeters, and this image was lateralized to the left in the upper portion to what it seemed to us to be the fallopian tube. In these images, there was no evidence of vagina. So with this presentation, we have done, here is the MRI. You can see the hematometra, and in the coronal image, you can see what it seemed to us to be an hematosalpinx in the left fallopian tube. So with this presentation, we've done an examination under anesthesia. There you can see the image from that. There was an urethra and an anus, but there was no vaginal introitus. We continue with a cystoscopy where we couldn't find any communication between the urological system and the genital system. And we continue after that with a laparoscopy. We could find the hematometra and the left hematosalpinx, but it was very hard to make a good interpretation of the genital system because of the surgical history. But in this approach, there was no evidence of vagina. So this could be an acquired vaginal atresia that explains perfectly the hematometra and hematosalpinx. With this information, we have done a percutaneous drainage of 400 millimeters of old blood, and the patient had a good evolution after this surgery and was discharged with a drain and menstrual suppression with Genogest and medroxyprogesterone. After that, she consulted to us 10 days after the discharge because she had abdominal pain once more, and in this case, it was with fever. The drainage didn't have any output, and on the physical examination, the abdomen was soft and depressible, but again, it was tender predominantly in the left iliac fossa. The MRI shows again an image that it could be an hematometra and hematosalpinx again, or because of the fever, it could be a pyometra or pyosalpinx. There you can see the MRI. It is very similar to the previous one, but there was something in the uterus and in the left fallopian tube. It could be blood or an infectious liquid. And with this new presentation, we've done a new exploratory laparoscopy. We could find the uterus and the left uterine tube distended, and we've done a puncture of the left uterine tube, obtaining purulent material. So there we arrived to the diagnosis of pyometra and left pyosalpinx, and we placed a new drain. We took the previous one and placed a new one. But after that, a couple of days after this surgery, she had abdominal pain once more, and the ultrasound showed a recurrent collection. So we have done a new laparoscopy and find again an hematosalpinx and pyosalpinx. So in this case, we were a little bit more aggressive, and we did a salpingotomy and placed a new drainage. But after that, 2 days after this surgery, the patient again started with with abdominal pain, and the ultrasound showed a recurrent collection. So we took her again to the operating room, and we've done in this surgery a left salpingo-oophorectomy and an uterostomy. The reason why we've done an oophorectomy, it was because it was impossible to separate the ovary from the fallopian tube. So the only way to take the fallopian tube was with a salpingo-oophorectomy, and then we've done an uterostomy to drain. So after that, the patient is stable, without fever and without pain and without output from the uterostomy, but we still have some doubts and some questions we wanted to discuss with you. Apart from listening your opinion, if any of you would have done something different, maybe a more aggressive approach in the first surgery. But apart from that, we also wanted to discuss what the next steps would be with these patients, how to resolve the acquired vaginal atresia, and on the other hand, considering her chronic kidney disease, we would like to talk about a possible future pregnancy and if this would be risky for the patient or not. And in case of being risky, the pregnancy, we would like to discuss if a salpingo hysterectomy would be appropriate for this patient or not. Thank you very much.
Thank you very much, Francisco. I think this is a very interesting case with lots of questions. I'm going to ask you to go back to the images where we can see the distended uterus there.
To the MRI?
Yeah, this one is
Okay,
a good one.
this was the second one with the pyometra and pyosalpinx.
Okay, can you see my arrow?
No.
No? Okay.
No.
So the uterus is there, it's dark, and it's above what is white, that it's the vagina. So if we look at the first image, we see bladder compressed near the pubic bone. The white portion behind the bladder is vagina, and then above you can see the
This
uterus.
one, you say this?
This is vagina. And if you just follow straight, like on a diagonal path, keep going, keep going, keep going. I'll tell you when to stop. Oh, no, back.
Yeah, well.
A little higher up, a little higher up. That's uterus, okay? So what you're seeing is vagina. And when you look at her sacrum.
All this is vagina, you say?
Yes.
Or the...
Yes, all the white is vagina. So when you look at the sacrum, now point at the sacrum, the last bone of the sacrum. So this vagina is actually reachable from below. So I have our gynecologist here. I hope she can speak. She's going to talk more. But our approach, if a patient comes with this is an acquired vaginal atresia because this patient was reconstructed for a cloaca. It was a short common length. So I'm assuming at the end of the procedure, you had urethra, vagina, and anus, and then the vagina closed. This was a question in the chat if this was acquired. Yes, it's acquired.
Yes.
So this patient, the questions that I have, how is bowel control in this patient? Does she have bowel control? That's number one. And number two is what type of drain are you placing? What size? Because it seems to be that the drain is getting clogged and that's why it's reaccumulating. And then your menstrual suppression is not adequate. She's not fully suppressed. The way we do it, if a patient comes to us like that, we would have IR drain, and we leave that drain until reconstruction. So we want to wait for the inflammation to disappear. We do menstrual suppression. We confirm that she's suppressed. But it's important to have the drain there because then during the reconstruction, you can fill with saline solution and this vagina will bulge and it will be easier to find this vagina and reconstruct. If the patient has no bowel control, very easy. You move the rectum and you have beautiful access. If the patient has bowel control, then you can decide to do a transanorrectal approach, that would be the mostly indicated, but this vagina is reachable from below.
Okay.
I just wanted to make a couple comments. Sorry I missed the beginning of the presentation, but was able to review the slides. I'm Veronica Alanis, gynecology at Children's Hospital. The other thing that we utilize, because this blood is generally like old, thick, very viscous blood, is you can do a dilute solution of TPA through the drain to like break up the clot so that it doesn't like clog the drain. So that's just another option just to help facilitate drainage. But I agree completely with Dr. Bischoff. Before considering anything definitive like a hysterectomy, would recommend trying to mobilize that vagina and do a vaginoplasty first. I know she has some kidney issues, and you're right to be concerned about that in pregnancy. Those kidney issues can worsen in pregnancy, but it's not a contraindication. And you know, we reserve hysterectomy for cases where there's really no in minors. You know, she was 18 years old and wanted to make that decision for herself, fine. But in minors, really needs to be medically indicated, and with no potential for fertility in the future.
Okay, thank you. So actually the patient.
Francisco, we lost you.
Yeah, we lost him.
I don't see, is Dr. Alanis still there? Dr. Alanis, can you comment on how you indicate menstrual suppression?
Yeah, so it can be tricky. Even our most aggressive forms of menstrual suppression, sometimes patients break through and have bleeding despite our best efforts. But generally, you know, we start with like high dose progestin therapy. In my opinion, that works a little bit better than like a combined birth control pill, which I think was used in this patient. The name is a little bit different because different formulations in different countries, but in my opinion, I think high dose progestins work a little bit better than a birth control pill. And then if that's not sufficient, then I will consider full suppression of the hypothalamic ovarian axis with something like Depolupron. So that is an injection that essentially puts patients in like a prepubertal or postmenopausal state. It's completely zero hormones. And that's okay to do for like 1 to 2 years, just while you're stabilizing the patient. It's not a long-term option because girls need estrogen.
Okay,
for
I'm
bone
back
health.
here. Could you hear my last comment?
I think you cut out and we didn't hear.
Now can you hear me?
Yes, we can hear you fine
Sorry
now.
for this. We have some problems with the Wi-Fi. But now can you hear me?
Perfectly, yes.
Okay, so now the patient doesn't have any drain. She just have the uterostomy. We have some doubts at the OR if that was the uterus or the vagina. It was a very thick wall, very muscular, so we thought it was the uterus, but maybe it is a vaginostomy. So we have some doubts with that. Anyway, she doesn't have any output from there.
So I think you're probably right to have some doubts. Sometimes just with the chronic obstruction, that vaginal wall gets really thick and inflamed, and so it can appear and feel thicker than what you would expect for a typical vaginal wall, but hard to know without looking at the pictures. I think what's going to be most important right now without a drain in place is that she is on good and adequate menstrual suppression. And so I was just, before you cut off, talking about some options in general. I prefer high dose progestins for menstrual suppression. I think it does a little bit better than like a traditional birth control pill. But if you want to be very aggressive, then you can do something like Depolupron, which is fully shuts down the hormone axis. So estrogen levels are very low. That's not a long-term option. It shouldn't be used more than 1 to 2 years because of the effects on bone health. But for the short term, while you're trying to stabilize a patient and make a surgical plan, it's totally appropriate to be more aggressive with the menstrual suppression.
Excuse me, I'm very sorry, but I couldn't listen to your last comment. Can you repeat, please?
I was just mentioning that you need to, like, I would be just make sure that she's on good and adequate menstrual suppression without a drain in place. So something like Depo-Lupron, which is an injection that suppresses the hormone axis, would be reasonable for 1 to 2 years while you're stabilizing the patient and making a surgical plan.
Okay, perfect. And the surgical plan for you, it would be a new vaginoplasty.
Yeah, I agree with Dr. Bischoff in that first
From a
thing
posterior approach.
Exactly, before considering a hysterectomy to try and do a vaginoplasty.
Francisco, even if the patient decides not to have her own kids, she would still need a vagina. So I think in this case, reconstruct the vagina, you will solve 2 problems. She will have a vagina for future intercourse, and the menstrual flow will have ways to drain. With this huge inflammation, we don't even know if she would be capable of conceiving naturally on her own, but I think reconstructing the vagina would solve the 2 problems. And there are many ways to reconstruct the vagina. There is a chance this vagina, after decreased inflammation, that this vagina would reach the perineum. But again, I would keep this patient drained, let all the inflammation. I would not try to attempt reconstruction for the next 6 months after having very good menstrual suppression, no infection, so you don't have inflamed tissue when you try to bring this vagina down. And then if not, you will have to be prepared to reconstruct with other tissues. So you can use a piece of colon, you can use a piece of small bowel. We are currently using alloderm, which is in Veronica, it's what type of tissue? It's cadaveric tissue that you can reconstruct, and they promote tissue growth.
Okay, perfect. And just to be sure, then you believe that all these collections have always been on the vagina. So these have always been an hematocol, no hematomet, no hematocalpings. It was always an hematocol.
So from the image, the distended portion is vagina. Now, those cases, there is sometimes fluid overflow through the uterus, through fallopian tube. And I understand when we say we can't say what is what, because it's true. Sometimes the tube is completely attached to the uterus. It's very hard to determine what is what. But the distended portion in that image is vagina. And I can see clear the uterus above. So if you bring that down, you will be safe.
Okay, thank you very much.
There is something called
and I'm sorry for the Wi-Fi.
There is something called index of suspicion. If you see a baby, a female baby with an anorectal malformation and a pelvic mass, it is a hydrocorpus unless you can demonstrate the opposite. So don't suspect, don't think about dilated uterus. It is the great majority. Your case is a dilated uterus would be an exception. The great majority of cases will have a dilated vagina. So that's at the beginning of the problem is the index of suspicion.
Thank you very much. I think this case generated a lot of discussion and it was very interesting. Dr. Diana, I forgot how to pronounce your last name.
Prasad.
Okay.
You can go ahead and present your case now.
Thank you very much, everyone. And I'm sorry for the Wi-Fi problems.
It's okay.
Okay. Good day. I am Diana Prasad and I'm from Trinidad and Tobago. And we would just like to say thank you very much for the opportunity to present our case today. So today we are presenting on a post-op Duhamel procedure with a likely anastomotic stricture. So this is our case summary. It's a 4-year-old female who is diagnosed with Hirschsprung disease at 5 months with a rectal biopsy. She had a leveling colostomy at 10 months of age and then a Duhamel's procedure at 1 year of age. She developed abdominal distension and had 2 episodes of Hirschsprung-associated enterocolitis the following year. She was being managed with daily rectal irrigations. Investigations revealed likely anastomotic stricture confirmed on barium enema and contrast-enhanced CT. She then had resolution of distension and was decompressing spontaneously 1 week post-CT. Our question is, what are the next steps? So we just have a poll. So the options are colonoscopy plus or minus balloon dilatation, or watch and wait, redo pull-through, laparoscopy, or EUA and repeat biopsy. Okay, so the majority said EUA and repeat biopsy. So now we'll just go through in some more detail about the patient. So her past medical history included history of an atrial septal defect. She was initially on furosemide and enalapril, and the ASD subsequently closed on serial echocardiograms. She also had a history of bradycardic episodes on induction of general anesthesia during a rectal biopsy. She had a history of lower respiratory tract infection with bronchospasm in February and November of 2023. And she also had a history of failure to thrive, which has now resolved, and a history of developmental delay, which is improving. So our current diagnosis is likely anastomotic stricture with gross colonic dilatation, previously requiring daily rectal washouts for decompression with a 24 French Foley's catheter. The CT was done 1 month ago and showed likely anastomotic stricture, the most proximal staple line and proximal colonic dilatation. However, currently, she has not required decompressions for a month and is able to pass flatus and stool spontaneously with no episodes of distension. So just a review of the procedures and imaging. So she presented initially in 2020 at 5 months with abdominal distension and constipation. Suction rectal biopsy showed no ganglion cells. She had a leveling colostomy and biopsy in November of 2020 with a subsequent revision of stoma secondary to stenosis. She then had her Duhamel procedure in June of 2022 with a post-op anal stricture, which resolved with digital dilations. She was noted to have mild abdominal distension in clinic follow-up. In October of 2023 and April of 2024, she had episodes of enterocolitis treated with IV antibiotics and rectal washouts. She had an upper GI contrast study, which was done for what we thought was gastric distension. However, it showed gross colonic distension and a normal stomach. So regular rectal washouts were started at that time. The histology was reviewed from the Duhamel procedure, and this confirmed ganglion cells present in the areas of the proximal stoma. A barium enema was then done in March of 2024, which showed a likely colonic stricture. Proximal to anastomosis was gross colonic distension. And finally, a CT was done in July of 2024, which showed a likely anastomotic stricture at the level of the most proximal staple line. So this is a picture of an X-ray which showed large bowel dilation. This was the barium enema showing a likely stricture at the green arrow. And this is an axial image of the CT showing the most proximal staple line with an area of narrowing. And this is a video showing the site of the stricture. So the challenges we had with this case, the patient had recurrent upper respiratory tract infections, which have delayed investigations. She had 2 previous episodes of enterocolitis and is at risk for future episodes. Due to previous complications with GA and recent resolution of symptoms, the parents are hesitant to proceed with further surgical therapy. And our questions are colonoscopy and balloon dilatation recommended or feasible for this case, or does the risk of perforation limit this intervention? Is laparoscopy to identify possible adhesions as a cause of symptoms indicated? And is a redo pull-through indicated? Thank you very much.
Thank you very much. I think with the X-ray and the contrast enema that you showed us, everybody will agree that this patient will need a reoperation. This patient will not be able to have a normal life without problems, without severe obstructive symptoms, without reoperation. I will let Dr. Peña and Dr. De La Torre comment, but the Duhamel, usually it's done with 2 stapler lines. And if the stenosis is just in the communication, I would try to enlarge this communication, restapling or making that communication wider and avoiding a full reoperations. Reoperations in Hirschsprung are never easy. Removing Duhamel pouches are never easy. So I think whenever you can avoid a big reoperation, it's better. Dr. De La Torre, your comments. Dr. Peña, your comments.
Hi, Diana. Yeah, I totally agree. So I think this patient is not having more Hirschsprung-associated enterocolitis. This patient is having chronic obstruction. The Duhamel was done like a end and lateral anastomosis in a not very good way. It's so high the anastomosis. The biopsy from the rectal pouch obviously is going to be aganglionic. So what I suggest in this patient, what you can do, because in this patient, because anastomosis is very high or proximal, I am very positive that this patient has all the circumference of the anal canal is intact. In other words, this patient has high chances to be a patient with bowel control after the reoperation. So the next operation should be a new redo, like a Swenson-like. You can start doing a transanal resection, saving or protecting all the anal canal. And then from the abdomen, you can finish the resection. Sometimes just with the transanal approach, you can do it. But always you need to do an abdominal approach, open or laparoscopic. I suggest in this patient to do an open approach because you need to find good blood supply for the pull-through. So this case could be resolved successfully with a very good operation. When we have a patient with previous Swenson or Suave procedures and they have this type of stenosis, then the possibility to preserve the bowel control is very, very low. So don't worry, Diana, you have a case that you can rescue.
Okay, thank you.
Dr. Peña?
The obviously this patient did not. If Dr. Duhamel could see this patient, he would be horrified. We don't do Duhamels, but this patient did not have a Duhamel. I believe that still the patient needs a more accurate anatomic diagnosis. Dr. De La Torre mentioned very well that he is assuming that the stricture is because they connected a piece of colon to the aganglionic bowel and a stricture very high. That operation is not a real Duhamel. That's why I said Duhamel would be horrified seeing this. So I would repeat the studies, including an endoscopy, to confirm that actually the original rectum is there, the pectinate line and the anal canal is intact, and then the problem is where they connected the normal ganglionic bowel to the aganglionic bowel very high, and if that's the case, fortunately, the patient will have good prognosis, as Dr. De La Torre mentioned.
Thank you.
Yeah, so just so everybody remember, I actually didn't make the comment because it didn't cross my mind. But when we do a Duhamel procedure, you're supposed to leave the rectum, and then you're gonna bring normal ganglionic bowel like behind the rectum, anterior to the sacrum, and then connect above the pectinate line and create a window with a triangle if you use a stapler, but it should be a big window. And that sometimes is what's stricture. But I don't think we even saw staplers in the contrast enema or in the x-ray. So it's a very good point. If instead what you guys did was leaving the rectum and just anastomosing above. I don't know if that's what was done. And
Hi, morning. I'm Dr. Lee. I'm the surgeon with the terrible Duhamel. We did do a retrorectal dissection and anastomosis. So we made the incision 2 centimeters proximal to the pectinate line, did the hand stitched anastomosis, and then ran the staple gun up to widen that anastomosis.
Okay.
So where the stricture is at the top end of the linear cutter with the top staple.
Okay.
But connection point between the pull-through segment and the rectum was at 2 cm proximal to the pectinate line.
So when you do a rectal exam, can you go through your anastomosis? Can you feel it?
Yeah, it feels wide. It feels quite wide. As far as my finger could go on a DRE, I can't feel that stricture. And we were only able to identify it when we did the imaging because it's quite high.
Okay.
Okay, then what we have seen in Duhamel's is that the piece of aganglionic bowel left in place becomes giant, dilated, and produces an obstruction. No stricture. It's just that bowel doesn't. We don't know why it becomes so giant, dilated, and we had to remove that and do a total redo. That's why we don't recommend Duhamel operation.
Okay. All right, because also below the level of the stricture, the bit of anastomose got that caliber of rectum. The original rectum is actually good caliber as well. There's just this one tight, short stricture at the very top end of the staple. So I don't know if it's adhesions that form there. I really don't know if it was a vascular injury to the bowel that caused a stricture or not.
In patients like this, in presentations like this, it is essential for you have in your mind the idea of the anatomy of your patient. You can make a beautiful diagram so people can understand. Because for you, in your mind is very clear, but in our mind is not clear. And what these patients needs is an anatomic diagnosis in order to plan the best way to approach the patient.
Okay.
And
Yeah.
Dr. De La Torre has offered, he placed his email there, Diana. So if you guys can talk to him, he will be happy to assist in every way that he can. So thank you so much for presenting this challenging case. And again, I think this patient will need a reoperation. And I think the mother will soon realize that too. So even if you don't push her, I think she will realize. So unfortunately, due to the time, we will have to postpone Dr. Johanna Cardosa's case to next time. I really apologize. I know she put a lot of work in organizing it. And thank you all for joining us. Today we have the pediatric surgeons from Argentina, Trinidad, Tobago, Italy, Mexico, Iraq, Uruguay, Brazil, Russia, Sudan, Uganda, Saudi Arabia, Germany, Indonesia, Macedonia, Ecuador, India, Yemen, Philippines, Nepal, and Paraguay. I think I got everyone, and Zambia. So thank you so much for joining us, and we look forward to have you in the next meeting again. Please send your case so we continue learning from each other. Thank you very much. Bye-bye.